Dear audience, in the next few minutes I will introduce the 18-month progress of our research about the umbilical cord and its effect on perinatal health. My name is Gréta Mayor. I'm a second-year PhD student and I'm working at Heim Translational Pediatric Institute. My vision is to improve the quality of life and extend the life expectancy of newborns. To achieve that, understanding the impact of umbilical cord coiling and management on perinatal health is my mission. To achieve my mission, I have two ongoing projects and specific goals. So now let me introduce my first one, which is about investigating the outcomes of neonatal resuscitation with and without intact cord. According to the guidelines based on the ICOR recommendations for those preterm and term infants who do not require resuscitation at birth, delayed cord clamping is or may be reasonable. Delayed cord clamping is associated with significant neonatal benefits, such as improved translational circulation, decreased need for blood transfusion, and lower incidence of necrotizing enterocolitis and intraventricular hemorrhage. Most newborns breathe spontaneously after birth, but around 15% of them require some degree of active resuscitation. The need is inversely related to the gestational age, so for example, for the very preterm infants, it is approximately 85%. Unfortunately, for these preterm and term infants, we have insufficient evidence on the optimal time of cord clamping. So our aim is to determine whether intact cord provides physiological, neonatal mortality and morbidity benefits for infants requiring resuscitation after birth. During our research, we examined how starting resuscitation before and after cord clamping affect the neonatal outcomes. We hypothesized that intact cord resuscitation is a safe delivery room stabilization method. Additionally, it decreases the incidence of neonatal mortality and morbidity and increases oxygen saturation level at 5 and 10 minutes after birth. We conducted a systematic search with this search key of 2 domains. It resulted around 16,000 hits, and after the selection processes, we had 10 eligible RCTs. After these, now let me show you our main results. On this first forest plot, you can see the result for one of the hardest outcomes, the in-hospital mortality. The overall risk ratio is 0.89. Next, you can see the analysis for oxygen saturation level at 5 and 10 minutes after birth. The mean differences suggest that in the intact cord resuscitation group, the mean oxygen saturation level was higher with 6.67% at 5 minutes and with 2.87% at 10 minutes after birth. On the following few figures, I will show the risk for different early complications of the prematurity. The overall risk ratio for all grades of IVH is 1.25, while for the severe IVH it is 0.96. If we examined only those studies where they used special resuscitation trolley, we see the overall risk ratio is 0.75. The next outcome is the necrotizing enterocolitis higher than grade 2. The overall risk ratio is 2.05. If we examined only those studies where they performed delayed cord clamping in the control group and not early cord clamping, the risk ratio is 2.89. And if we analyzed only those studies where they used special resuscitation trolley, the risk ratio for NEC higher than grade 2 is 1.22. The last early complication of the prematurity is the retinopathy of the prematurity requiring treatment, and the analysis resulted in a risk ratio of 1.60. Here I prepared a summary table of our further outcomes, and I would like to highlight the results of delivery room parameters, such as the Apgar score and the temperature at admission to the NICU. And we can see that in the intact cord resuscitation group, the results are not worse than in the control group, but about the later complications, it is not that clear. So, unfortunately, none of our results reached the statistically significant result, level, and probably the reasons can be the small sample sizes and even numbers, the different definitions of the outcomes, the heterogeneous protocol of the intervention, and the various resuscitation platforms among the studies we analyzed. Considering our research, we have some strengths as well. For example, we included only RCTs in the meta-analysis to reach a higher evidence, and we examined the broad population, preterm and term infants. We had 17 analyzed outcomes and detailed subgroup analysis. In conclusion, we can say that intact cord resuscitation seems to be a safe delivery room stabilization method. Due to the potential beneficial effect of intact cord resuscitation under oxygenation in the term infant population, recommending intact cord resuscitation may be justified. However, in the preterm population, intact cord resuscitation should be applied with caution due to the potential for the early complications, and we recommend to perform it only in specialized centers with appropriate expertise, protocols, and equipment. And based on our results, the use of the special resuscitation trolleys appears to be beneficial. As there is still no strong and clear evidence about the optimal umbilical cord management during neonatal resuscitation, we recommend to perform and conduct high-quality RCTs with larger sample sizes, with standardized protocol interventions and outcome definitions, and it is very important to differentiate outcome data between infants requiring stabilization measures after delivery and those who are not requiring it. For our first project, we finished the manuscript, and we are planning to submit it in the near future. However, as the first systematic search was more than 1 year ago and the sample sizes are small and we have lack of statistically significant results and strong conclusion, we decided to update the systematic search and contact the corresponding authors who did not reply to us previously and then submit it again in spring. So in the last couple of minutes, I would like to say some words about our second project as well, which is about investigating the association between umbilical cord coiling index and perinatal outcomes. Umbilical cord coiling is the coiling or twisting of the vessels within the umbilical cord in a regular helical pattern. This is usually assessed by the umbilical coiling index, which is defined by the number of complete coils per centimeter length of cord. It is usually measured sonographically during antenatal follow-up or postnatally, and it is believed it is related to the gestational age. Intrinsic developmental abnormalities and the early fetal movements can impact the coiling of the umbilical cord, and it can cause hypocoiled and hypercoiled umbilical cords. As we know that the alterations in the umbilical cord blood flow can cause physiological changes in the newborn infant, it is believed and now observed too that hypo and hypercoiled umbilical cords can lead to perinatal pathology. So our aim is to evaluate the association between the abnormal umbilical cord coiling and adverse perinatal outcomes, and to find out if this umbilical coiling index is a reliable antenatal biomarker. So the clinical questions are, is umbilical coiling index is a reliable antenatal biomarker, and what is the ideal time of antenatal assessment of the index? We hypothesize that the abnormal degree of umbilical cord coiling is associated with adverse perinatal outcomes, and that the umbilical coiling index is a reliable antenatal biomarker for perinatal pathologies, and also that the degree of the umbilical cord coiling does not change after the first trimester. The clinical implication is recommendation of the umbilical coiling index assessment to predict perinatal pathology. Here you can see a short summary of my previously introduced projects. The first one was about the umbilical cord management during neonatal resuscitation, and the second one is about the umbilical cord coiling index and perinatal outcomes. We are planning to submit the first one in March and the second one in September. And I would like to finish my presentation with one of my favorite quotes by Ray Goforth, which is, "There are two types of people who will tell you that you cannot make a difference in this world. Those who are afraid to try, and those who are afraid you will succeed." Thank you for your attention.
Did you get any significant results or differences in the first study?
No, not
No.
statistically significant.
Therefore, it's very hard to draw any conclusions.
Yes.
And so very recently in the Lancet, probably in the Lancet, was published a work which tells that if during the delivery room resuscitation the cord clamping is over 2 minutes, then the mortality declines. Probably, did you read this paper?
Yes.
Okay. So, this is very hard, that because this was not a simple RCT, it was a systematic review.
Yes.
How on earth they could get another conclusion than you?
They included more studies, like studies where the population was mixed, not just those who really required resuscitation after birth. We just have 6 studies, 6 RCTs in our meta-analysis because we contacted all corresponding authors who had trial about this topic, and we wanted to ask if it wasn't clear, like how many % of the infants really required resuscitation. And out of the 10 RCTs, only 2 replied, and 4 was clear out of the article. So we could only include 6 because we made sure that those 6 really contained those infants who really required resuscitation, and the other 4, which could be also included in this one, they had like 40% or 30% of the...
Probably, do you try to get individual data as well?
We tried, but we couldn't get.
Okay, so this is a quite troublesome situation. But hopefully, will you succeed?